Welcome to this featured session on strengthening families that asks the question, how do communities come together to better support all children, not some children with identified issues or high needs, but all children? I'm Donna White, the Vice President of the North Carolina Partnership for Children, the administering agency for Smart Start. And it is my pleasure and honor to be moderating our panel of experts this afternoon. They bring a great deal of experience in community family strengthening systems and have a large amount of information to share. So I want to turn this over to them as quickly as I can. It's been a blast planning with them, so I know that you're going to enjoy this session. And since they have so much information to share, I am going to be keeping the process moving. Each panelist is going to provide an overview of key information from their work. I'll follow up with a couple of questions, and then we'll save a few minutes for questions that you may have as well. So our esteemed and accomplished guest panelists are, at the far end is Dr. Neal Horen, who will bring a national perspective. Neal is a clinical psychologist and director of the Early Childhood Division and co-director of training and technical assistance at the Georgetown University Center for Child and Human Development. He's worked closely with numerous states, tribes, territories, and communities in supporting the development of systems of care for young children and their families. In the middle is Claudia Zundel. She'll bring a state perspective from her experience in Colorado, where she is the director of Child, Adolescent, and Family Services, which is a shared position with the Office of Behavioral Health and the Office of Children, Youth, and Families. She has served as a principal investigator for several grants related to early childhood mental health, including Project Bloom, which was the first system of care grant in the nation that explicitly focused on young children. And then to my right is Dr. Dana Hagele, who will bring a state perspective from North Carolina with a little more focus, a little more programmatic focus. She's the co-director of the North Carolina Child Treatment Program, an implementation platform for the dissemination of evidence-based child mental health treatment models. And she also serves as a board-certified child abuse pediatrician at a child advocacy center in Burlington, North Carolina. Please help me welcome our guest. Okay, Neal, so why don't we start with you, and can you begin by painting us a picture of a family to help make this real?
Sure. So I'll do it by speaking both to the bride's side and the groom's side. Sometimes I'll do this as an activity, but I want you to sort of think about this in this way. I want you to keep in mind a child and a family when we talk about systems. When we talk today, you're going to hear about all this theoretical sort of things and big picture sorts of things. So just imagine a 26-year-old single mother, 4 children, a 7-year-old, 6-year-old, a 4-year-old, and an infant. And the 4-year-old is in some sort of child care and has been expelled from 2 other child cares. And this mother is getting calls left and right saying you need to come pick your child up. And numerous people have over the course of months and maybe even a year said, I have something that might be helpful for you. And she gets sent to some places, and she gets referrals and pieces of paper. And her boss is asking her, why do you have to keep cutting out of work? I'm really concerned. And some of the places she goes are really helpful, and some of them are not so helpful. Some of them are dead ends. And she's getting more and more frustrated. And when I tell that story, in many places across the country, people say, well, that's what happens here. And my guess is that for some of you, that's not what happens, that you live in places across the country where you've really figured it all out, your system's humming along, every family and child are getting what they need. And I'm guessing that there are some people here who that story resonates for, because in your community, in your state, in your country, in your tribal nation, wherever you're from, there are still kids and families who are not getting exactly what they need. And when we talk about systems, ultimately what we're talking about is how do we help a family where there's a need like that? And how do we assess what's really going on and what kinds of services and supports, including natural supports, are going to be most helpful? And so I want to talk about systems, and at the end maybe I'll try and come back to this family, but I want you to maybe think about this family, or maybe there's a family you're currently working with and trying to support and trying to partner with, that when you think about the system, you're like, boy, the system for this family's not getting it done, or there's certain parts that aren't. So when we talk about systems, I want to do a little bit about what a system of care is. And I've spent the better part of about 20 years really trying to help, as Donna mentioned, in lots of different ways, folks think about their system. And so when they said you have 20 minutes, it reminds me of how when my mom is about to tell a story, I'm like, you got to hurry up, I got to go. And she's trying to tell something really quickly that I know she wants to spend more time talking about. So we're going to talk about systems of care, which oftentimes take 15 or 20 years to really develop a system, and I'm going to try and do it in 20 minutes. So I'm happy to give everybody the slides at some point if you want them, but I want to talk a little bit about what makes an early childhood system a little bit different. So you may be familiar with the concept of system of care, but when we talk about very young children and their families, there are some differences. Talk a little bit about some strategies across the country that have been effective. And again, we're going to sort of skim the surface here. And if you want more details, happy to sort of give folks an email, and you can email me or call me and say, hey, I really want to know a little bit more about what they're doing in Connecticut or somewhere else. So a system of care is not sort of a manual and you just do steps 1 through 10. And folks like Claudia, who I've had the pleasure of working with over the years, will tell you it's sort of a way of being. It's a philosophy. And it's really based on this idea that we're building capacity, and especially in early childhood, it's the idea that we shouldn't wait until children need treatment. That we know very early on, you hear this all the time. I'm a child psychologist, I still see children and families, and I will tell you, most parents know very early on there's something going on with my child. The system sometimes takes a while to catch up, but parents usually know very early on. And what we're trying to do is talk about promotion and prevention, as well as intervention, but how a system really does all of those for all the children and families, and not just wait until a child's 9 or 10, already in an IEP process, in an individualized education plan process. So we'll talk about sort of what that means. Here's some core values, and those core values some of you have seen, and these certainly apply to sort of all systems building efforts. But community-based is a big piece of this, and in particular for very young children and their families, we need to think about culturally and linguistically competent sorts of systems. So if we had more time, I'd ask people here, when you had a cold when you were younger, what did your family do? And there are going to invariably be people in here who will say, I had chicken noodle soup, I had orange juice. Somebody's family gave them whiskey at some point early on in their life because that somehow helped. Somebody else had a grandma or an aunt who went out in the yard, got a root, turned it into a tea. Many of us have had foul-smelling things smeared on our face or our chest, and we all had the same thing. We had a cold, we had flu, those kinds of things, but our families and our culture and our communities handle those things differently, and that's physical health. And now we're talking about social emotional well-being, which is so loaded with other sorts of things to think about. We know that children are being kicked out of childcare. We know that the expulsion rate for very young children is actually higher than children being kicked out of primary school age and high school. We know that there are things around trauma and the adverse childhood experiences, the ACEs study. We know that there are parental family risks. We know that there's lots of risk factors, and we've done a lot of work. There's some great work being done about the impact on brain development and what happens in those first 1,000 days of a child's life. We know this, we know the context. And we know that children with challenging behavior are much less likely to be successful in kindergarten. My mom's a kindergarten teacher for 35 years in New York City public school systems, and she and I talk about this. I mean, I cut her off just like we're doing here, but we talk about this all the time, and she said, you know, if children don't know how to read or their numbers or colors or shapes when they come to me, I can do something about that. But if they come to me when they're 6 years old and they don't know how to interact with their peers, they don't know how to follow directions, they don't know how to problem solve, manage their anger, it's much more challenging. And we know this, that we have these opportunities very early on in a child's life to address this. So how do we do this? We promote emotional well-being for all. We don't just sort of identify those children who are at risk or those children who need some sort of evidence-based treatment. We try and do this for all children. And we help families address their own barriers and ensure some sort of access to services and supports. This is our cutesy little sort of diagram of what a system looks like. And what you'll see is that there's some values there. And what we're trying to do is promotion, we're trying to do prevention, we're trying to do treatment, and in the end, we're trying to foster resilience. What we're trying to do is help children and families succeed. And to do that, to build a system, really involves a lot of very complex pieces that I'm going to try and go over about a minute each. Governance, and your workforce development, and financing, and data collection, and things like that. But in the end, that's what you're trying to do. This is a very complex thing to do. Doesn't mean it can't be done. But you have to think about all of these pieces. So it's really, for those of you who may remember, there used to be a guy on TV who would spin plates. And he'd have a plate on a stick, and then he'd have another one. He'd have all these plates spinning. And he'd have to sort of run and try and do it. I'm not old enough to know this. I just heard it from someone else. So that's really what building a system is spinning lots of plates and maybe trying to get other people to help spin the plates and not trying to do it yourself, but really building this partnership and this collaborative effort. What's different for young children is that the partnerships look different. Young children are not all in a school. Some of them are in kith and kin care. Some of them are in licensed child care, some are in unlicensed child care. Some are in early Head Start, some are receiving home visiting, some are in their primary care docs. Hopefully all of them at some point are in their primary care doc's office. And so the partnerships really look different than when you're working with older children and their families. Engaging families is oftentimes different. When we try and engage families in systems development, when their children have been through the ringer, and they've been through processes with the school system and juvenile justice and child welfare and all these other systems, they're ready to advocate. But when we work with the parents of very young children who've never had a negative experience with the system and all they want is to get a couple of services and supports for their child, it may be somewhat more challenging. It's really important to bring them in, but it may look different. And the most important part, and I'm a child psychologist, so I pay my mortgage doing this, but it's not a mental health system of care. It's a system of care. And it's about the whole child and the whole family. It's not just how do we figure out this mental health side of things. Engaging families is critical. You can't build a system and then say to families, see what we did? Isn't this cool? You have to have families all along the way informing the system. I'll tell you a quick story about in Maryland where they have built up their mental health consultation services. And the way that they did it was they had families come to the legislature and talk about their experience and use that plus data to help convince legislators to fund mental health consultation. Partners. As I said, you're not going to build a system by yourself, and so you have to have representation from lots of different agencies that impact on very young children and their families. The medical community is key. Most young children, I know this is a broad statement, most young children are going to get their care, their mental health care, from their pediatrician. And the way they get it is they say, you know, I'm really concerned that he's doing this. And the pediatrician who's trying to get their work done, their visits in, their screenings, all the things that they need to do, has the opportunity to say, boy, that's a really interesting sort of concern. Here's what I think might be helpful. And there are places actually right here in North Carolina, not very far, like Alamance County, North Carolina, that have done some amazing things about embedding their sort of behavioral health folks in primary care offices so that you don't have to give a piece of paper and then someone like this mom that I described has to run around trying to find it. They're right there. There are lots of models across the country where these things are being done. In terms of partnerships, again, this is only for some of you in the audience. I can see the ones who have no idea who this bear is, but he's very important. For those of us who had a TV that had 3 channels, this was one of the commercials we saw. And you made your sister or your brother change the channels. That was a remote control. So this is Smokey the Bear, and he was supposed to prevent forest fires. He's like, only I can prevent forest fires? Don't you think you should share some of the responsibility? And the reason I put that up there is that when we talk about young children, it's everyone's responsibility. It's primary care doc's responsibility, it's mental health's responsibility, it's the school system, it's child care, and when everyone sort of sees it as their collective responsibility, much more success. Some examples. In Maryland, the children's mental health director for the state and the state superintendent for special education said, we got to do something here. So they started, which continues today, this is about 15 years ago, a mental health steering committee, early childhood mental health steering committee. That committee is comprised of folks from all the different agencies that might have something to do with young children and their families. There are family members on there, family leadership from Maryland, there's child welfare, there is education, there's juvenile justice, there's mental health, and decisions get made in that steering committee about which grants you're going to go for and how you're going to implement them, rather than each state agency sort of figuring out their own plan. Massachusetts they had too many plans, and what they did is they said, we got to figure this all out, because they're getting lots of money from the federal government in terms of grants and huge efforts, and what they then did is said, let's make a plan. We have some incredible health care going on here in Massachusetts, but we have all these plans. Project Launch, which also is here in North Carolina, and some of these other sorts of efforts are good examples of where governance and interagency partnerships are really emphasized. Workforce. I once made this mistake at a conference. Somebody from Iowa said, well, what about the workforce? And I said, because I'm sort of arrogant, so I said, well, it's not like there's a bus sitting in Arkansas filled with mental health professionals ready to come over the border. And then the woman said, that's because we don't share a border with Arkansas. So I think that when we think about Project ABC in Los Angeles is a great example of how folks think about workforce development and how they sort of say, we're going to build the entire workforce. We're going to pay attention. In Connecticut, they have something called Charts a Course, which takes folks from an AA degree to a BS or BA degree, all the way to a master's and a PhD, and says all of the universities in the state of Connecticut are connected, all the community colleges in terms of where you earn your credits. We have common curricula. Those are the kinds of things that can help with workforce development. I'd like you to take out a piece of paper and number it 1 to 10. There's going to be a quiz on this at the end. This is what financing looks like. And Claudia actually has, in Colorado, they've done an amazing job of sort of making sense of this by saying, we're going to start to try and figure out where's all the money come from and where does it go? And until you know the answer to that, you don't know financing. So in your state, in your community, there's money that comes from the federal government. It goes to the state government. It goes out to cities and counties and towns. And knowing that and being able to track that helps you figure out, well, how are we spending the money? There are great documents by Kay Johnson and National Center, NCCP, it'll come to me, National Center for Children in Poverty, that have done Making Dollars Follow Sense and other documents that sort of talk about financing. But you have to understand financing. You have to sort of leave no stone unturned. So you can see I love my folks in Colorado who have done this around mental health consultation. CEFL, the Center for Study of Social Emotional Foundations for Early Learning, thanks. Project Launch in Maine has really done a lot of work around how they pay for things. These are some examples of places across the country that have done some interesting looks at how they maximize funding. There's something called the DSM, the Diagnostic and Statistical Manual. It's on sort of whatever revision it's on. That's used to sort of make diagnoses. The challenge is that it doesn't really apply to children birth to 3. And there's a whole other world that's been put out called the Diagnostic Classification System 0 to 3. Some places, Florida, these are just 3 examples, there are other places, have done crosswalks so that we can actually give an accurate diagnosis whenever that's necessary. Lots of children won't need a diagnosis, but if they do, we want to do this. Claudia and I were talking last night. I wanted to talk about the basketball and hockey, but she wanted to talk about Medicaid. And so we split the difference and we talked about Medicaid. So thinking about Medicaid, since that is the place where a lot of this funding comes from, is really helpful. And in Colorado and in a number of other places, they've really thought about how do we pay for all of this? You got to talk to folks. Dana's going to spend a little bit of time talking about data. Data is money. So in Milwaukee, when they were collecting data, what they said is, if I'm talking to somebody from child welfare, I'm going to talk about the issues that are germane to child welfare. I'm talking to somebody from education, I'm going to talk about education-related data. And using your data as a source of communication, and then having a communication campaign, a way of helping people understand why we need to invest in early childhood. You know, early childhood, most of us in this room, obviously, are going to say, it's great, we got to do stuff. And yet, if you get out of this conference, if you go out in the rest of the world, they don't care. They don't want to spend money on this because 3-year-olds don't vote. I mean, in Chicago they do, but they don't vote anywhere else. And so, because they don't vote, we don't pay a lot of attention to them.
Neal?
Yeah, thanks. Public health approach. Not thinking just about treatment, but about promotion, prevention, and intervention. Good examples of this, quality rating in terms of child care. In Louisiana, they've done this amazing thing where the higher the quality of your child care, if you're a licensed child care, you actually get tax benefits. And if your child goes to a more highly rated child care, you get tax benefits. That's a very complex thing to do, but boy, it sort of suggests that they're paying attention to this. So I'm going to we're going to talk a little bit about prevention strategies. Many of you are familiar with things like home visiting and mental health consultation. In terms of intervention, wraparound is a concept that has been used with very young children, but lots of things like parent-child interaction therapy and child-parent psychotherapy, CPP, having hotlines for families. These are the kinds of strategies you want to think about. Outcome data. So actually a bunch of these folks had system of care grants focused on early childhood, and they looked at these kinds of specific behaviors so they could show the impact. You have to be able to show the impact of what you're doing. It's not a mental health system of care. I can't emphasize that enough, and I'm a mental health person. It's about everything that's related to that family. Here's something about what we've learned about sustainability, that you have to sort of think about sustainability from the beginning. There's lots of other pieces of this, but you have to think about it, and you have to have some sort of leadership and champions along the way. Claudia is a great example of this. There are lots of others across the country. She just happens to be sitting here, so I have to be nicer. But there are lots of good examples of folks who've really championed this for years and years and years. I like this because these two folks have this unbelievable complex math equation, and in the middle it just says, then a miracle occurs. And the guy says, I think you should be more explicit here in step 2. It's not a miracle that's going to help this 26-year-old mom. It's folks in this room who understand how to work together, how to build a system, and how to take lessons learned from all the places around the country that have addressed things like workforce development, sustainability, financing, all those kinds of things. What you'll hear next is you'll hear more concrete examples of what it looks like at a state level and what it looks like at a local level. So thanks for your time.
Thank you, Neal, so much. Claudia, let's hear about your community work in Colorado.
Good afternoon. Thank you. I like participation. So it's wonderful to be here, and I just want to share a little bit about my job, because this has kind of been my MO for a number of years, where I can't get any one office or division to pay my salary, so I find 2. So right now, I have the Office of Behavioral Health and the Office of Children, Youth, and Families, which is where Child Welfare Division of Youth Corrections is. But when I was heavily involved in the early childhood mental health world, I had the Division of Child Care and the Office of Behavioral Health that paid my salary. And that was actually a very good connection. So I want to warn you about a couple things. First of all, I love pictures and I love metaphors. So you're going to see a few of those in this presentation. What I'm going to talk about today is mostly adaptive change. Has anybody read the book, Leadership Without Easy Answers? Okay, good, thank you. Well, in that book, they talk about 2 kinds of changes or challenges. There's technical changes or challenges and adaptive. Technical are things where there's an expert, there's an answer, it's kind of routine problems. But adaptive challenges are where you have to change the way you think and change values and beliefs. And so that's mostly what I'm going to talk about today, because I think the technical pieces, there's many, many people around the country that can share that. And throughout this presentation, I have a lot of resources for you too that I think share some of those more technical pieces. But we found in Colorado that there were 3 main strategies that really helped us move early childhood mental health. Organizing, and by organizing, I mean organizing people and ideas and connecting things, leadership, and that's in many different facets, and use of data. I didn't put financing up there because certainly financing is very important, but I think these 3 things lay the foundation for financing. So when we began in Colorado, it was like that distant mountain peak. I always have to do my Chamber of Commerce, you know, the mountains. It seemed like getting early childhood mental health to be a focus was like a distant mountain peak. We didn't quite know how to get there. And so we began very simply by some pilots. And at the very beginning, we had 2 different types of pilots. One was organized around early care and education, and we called them the Consolidated Child Care Pilots. And one of the really great features of these communities could get together, organize all their early care and education folks, and they could apply to the state for waivers of rules and regulations. And that turned out to be a very successful strategy, and a lot of policies were changed as a result of people testing out different ways of doing things. But in time, those consolidated child care pilots actually evolved into early childhood councils. And those councils now went beyond just early care and education. They also covered parent support, they covered social and emotional and mental health and health. So they really began to cover a comprehensive system of care. At the same time, not related, we had mental health pilots that were going on. So we had a couple of mental health centers that placed mental health consultants in child care centers to begin the work of providing mental health services. I can remember early on the legislators were just shaking their heads. What are you talking about? Mental health and early childhood? That's just behavior problems. And then the mental health folks were saying to us, what are you talking about, early childhood mental health? That doesn't happen until kids are adolescents. So it took a long time, really over the course of 10 years, for people to realize that there were issues in early childhood. The mental health pilots eventually evolved into having an early childhood mental health specialist in each one of our public mental health centers all across the state. So one of the things we did early on in terms of organizing is we had this grassroots group of some of these pioneers that I just mentioned who were meeting together every month, and they had a conversation about early childhood mental health. And we said, why don't we take this up a notch? Let's have a statewide gathering of everybody in the state who's interested in early childhood mental health. At that time, there had never been such a gathering. So we decided to invite a few people and started getting out an invitation. But before we knew it, people were banging at our door to be a part of this conversation because it was the first time that people had come together to really talk about early childhood mental health. We had 100 people at this gathering in the middle of a snowstorm. It is Colorado. It snows. But that gathering showed us how much pent-up energy there was to talk about mental health. After that gathering, we got a number of resources and some leadership in place. So we got the first System of Care grant that explicitly worked on early childhood mental health, Project Bloom. We have Kid Connects, which was one of those pilots that turned into a model program and was also displayed on Georgetown's model program website. So we had a model in the state that had a manual, it had training, and it was really served as a clear demonstration of what mental health consultation could do. We had the early childhood specialists in each one of the mental health centers. We had CEPHL. And what we decided to do was to pull together a blue ribbon policy council. It didn't make sense for all of these groups to have their own council, so we pulled them all together in a blue ribbon policy council. All right, here's one of those metaphors pictures I told you about. So these are my border collies, and they love to play Frisbee. So Gizmo, the dog with the most black, When you throw the Frisbee, he runs all the way down the mountain, picks up the Frisbee, and starts back up the mountain. Bandit, the dog with the white on her face, waits by me, and as soon as Gizmo comes up, she grabs onto that Frisbee, and they bring it in together. So I ask you, do you not know people like this in our field? So we talked about organizing and how that can be a strategy. I also want to talk about leadership and the Blue Ribbon Policy Council. There's many, many ways to provide leadership. Wherever you sit in the system, you can provide leadership. I heard a saying the other day that I really liked. Leadership is a process. And so that's what I think the Blue Ribbon Policy Council was, an opportunity for many leaders from different disciplines and different areas to come together to form a state plan. And these are the 5 goal areas that we had in that plan. This was our vision. We were so proud of ourselves. We did focus groups. We went across the state, and we came up with what we thought was a wonderful vision. All children will reach their full social, emotional potential. And we took this out to some parents, and they said, "What are you talking about? Aren't you talking about that you want to support children to be happy, healthy, and have good relationships with others?" We said, "That's it." I know this is hard to see, but this was a very, very important document in our early childhood system of care. This is the Colorado framework, and it shows the 4 different dimensions that we talk about in a comprehensive system of care. It has early learning, it has family support, it has social emotional health, and health. This document really helped the system understand that everybody had a role to play. The way this was created is a couple of really smart people got in a room together, looked at all the documents and plans that had been developed across these domains, and put this framework together. And it's been very, very helpful to help people see what a comprehensive system looks like. So the use of data, I just want to talk very quickly about a couple ways that we were able to use data. At the beginning, we used some cost of failure studies, so it was hard to demonstrate in mental health consultation what you were preventing if it didn't happen. But what we did was take a few families, a few situations, and played out what would have happened if the course was not changed, and put a dollar amount to that. And that was a very powerful tool to use with legislators. As we got more sophisticated, we talked about return on investment. I also want to mention the Colorado Health Survey, which our public health department sends out a survey of parents, and what they do is let other agencies buy a question. So we bought a question about social emotional health and how many parents were concerned about their children, and that was helpful because that showed us how broad concern was across the state. And then one of my colleagues did a study where she, in Colorado, looked at how many children were expelled from preschool. Because you know, national data doesn't mean anything. It has to be the data in your state. And then we were able to use that data in a lot of really creative ways. We had this fact sheet called the ABCs of children's mental health. That was really helpful to share with partners. One of the things we did for Children's Mental Health Day was design these bookmarks. You can see it says, "What's bugging you?" And it's a list of books that talk about children's social emotional health that's relevant for preschool children. We partnered with libraries to give this out. And then I want to play for you, hopefully this will work, a radio spot that we used that actually took some of this data and put it into a child's view. This did work. That's pretty good, huh? All right, we'll just move on. Wow, I just really... Okay. That's actually not what it sounded like, but I think you get a message. All right, well, it was a good thought. It was a very cute radio spot that actually had a child talking about what she would want people to know about her feelings. Sorry that you couldn't hear it. So this is one of the goals that we certainly worked on through the state plan was professional and workforce development. Neal mentioned the pyramid model. That was one of our workforce development for child care workers. The DC 0 to 3R, which we talked about for mental health professionals, and the Colorado endorsement. How many people have heard of the Michigan culturally responsive, relationship-focused practice for promoting infant mental health? Known as the Michigan endorsement. How many people have heard of that? Okay. Well, we adopted that in Colorado, and of course we had to call it the Colorado endorsement. This is a way we thought about the different programs and services through the public health triangle lens. So these are the 6 strategies that we found really important to offer, regardless of whether we were doing it at a promotion level or an intervention level.
Claudia, just another minute.
Okay, another metaphor. So one of the things we struggled with was in our system of care grant, we had to focus on children with the highest need, the most severe need. And that was hard for early childhood mental health because, as Neal said, this is something that needs to cut across the population. So one of our colleagues said, well, it's kind of like trucks. You know, when you build the roads, you build them so that the heaviest trucks can drive on them, and then all the other vehicles can use them as well. So I just very quickly want to talk a minute about Part C. Does everybody know what Part C is, early intervention? This was one of our partners that we found a lot of common ground with. We were able to create a shared plan that used wraparound and their family support plan. We were able to use the DC 0 to 3R as an eligibility for early intervention services. They renamed one of their interventions as social-emotional interventions. And then we also created a screening protocol for pediatricians to use to know when to refer children. TANF was one of our more unusual suspects. We were able to get some funding from the Temporary Assistance for Needy Families to help support mental health consultation, because one of the reasons that parents have trouble getting to work or getting to work on time is because they're being called to come pick up their child. And I just have to share with you that, you know, people talk about finding the barriers to being successful. Well, we looked in Colorado and we found the barriers, and that's why we're successful. This is a quote from one of our evaluators, and these are some of the things that are happening currently. We have a whole office of early childhood. We've started to work with child welfare, trauma, ACEs. We have an early childhood commission, which is high-level people really taking a look at early childhood. We're also talking about the 2-gen approach. Anybody heard of that 2-generation approach? Certainly early childhood fits there. I just have to end with, we're changing one of the people at our premier child care center said, we're changing the world, one family and one child at a time.
Thank you, Claudia. You have done some amazing things in Colorado. It's really inspiring.
Good afternoon. I have the unenviable task of being the 3rd speaker after lunch, so I'm going to use a louder voice than usual and a faster one, and I'll keep you on your toes. I am Dana Hagele, and I'm here to talk a little bit about how communities can come together. And the idea of data, which is such a weird thing for, you know, a group of people who like to help others, but data really can be the common language that we speak to each other, to our legislators, etc. So that's going to be the focus, and I'm going to try to make data fun. So just nod and smile, and I'll feel encouraged. And the bottom line is this. We're all here because we care about early childhood and families. And the way I see it is we've come together because we want to help children and families obviously reach their potential and be prepared for success. And so the question really is that I would ask myself, how do I steer by the north on my compass? And what are the big questions that we need to ask when we go into work? I think an important question is, why do families actually participate in your program? And that's something you should be thinking about. Or, why do stakeholders actually refer families to you for services? Why do advocates go to your General Assembly to advocate for you? And why do funders actually invest in what it is that you do? And I think on the most basic level, it's because you, in your programs and in your communities, identify issues or problems or things that you want to promote, and you bring families from a place where they have a need, and you somehow satisfy that need so they reach their potential and they thrive. That's the most basic kind of currency of why we're all here together and why we do our various jobs that might look different on the surface, but fundamentally this is what we're doing. So then the question becomes, if I'm going to work every day to move a population from one place to another, how do I know that I've actually met that goal, my unique goal as an agency, and then how I plug into the broader system of care? So the interesting thing is data. And I think a lot of us are in the habit, whether it's for a grant report, whether it's for a report to your General Assembly, whether it's a report to a boss. There's lots of stuff that we measure that we call data. And in general, it tends to focus on things that are easier to measure. Things like utilization. What is the cost of this delivery of this service? How much access do people have to our services? And when they get that access, are they satisfied? So these are the things that we tend to focus on, report on, and count. And a lot of times we don't stop to think about, and what was the point of all this? And so what I'd like to suggest is that absolutely things like utilization and satisfaction and performance and cost are important. They're part of what we do. I think the other piece is that outcomes from an agency perspective, from a service provider's perspective, are critical, and then also our collective impact as we're a part of a system of care serving young children. So what I'd like to suggest is what you do, hopefully, is stuff that works. So my bottom line assumption is when you go to work, your program is instituting a program that has some sort of evidence base to it or evidence informedness, but that overall you are moving a population through a good thing to better outcomes. And when I talk about data, there's kind of three big clusters or three big buckets maybe that we'd want to think about. First of all, you actually need to know what your general population needs, your community needs, or an individual family or child. And that's that idea of assessing need, which is data, and you actually all do it and probably didn't know that's what you were doing. The second is, how is my program performing, or how is my system of care in my community performing? And that is that stuff like utilization, cost, satisfaction, fidelity, all that kind of good stuff. And then here's the issue that we don't necessarily think about as much, and that is the actual outcomes at the family and the community level. Are symptoms gone? Is functioning improved? Is there a diagnosis that has been stabilized? These are kinds of things that are an outcome. And then there's impact, like, is this family more functional? Is this family engaging more in good stuff like school and education? Are kids graduating? Are kids going to be productive members of a workforce versus being in a jail or an out-of-home placement? And so that's that idea of measuring what we've actually done. So obviously those are nice theoretical principles, and then the question is, well, what do we actually do? And what I would say is the most basic unit you need to be thinking about as an agency, representing your agencies and going back, is what is the need? What are we trying to achieve, in other words? What are we trying to make better? What are we trying to fix? Or what are we trying to promote or improve? So that's that at child and population level in your community or with an individual family. And then there's the actual performance. What did we offer? Did we offer it well? And then finally, the piece that really is critical, and that is, and what was the outcome at that family level across all the families we serve in our agency, and then as we come together collectively at an interagency council or some other format, some other forum, what was our actual collective impact? So for me, going to a lecture has to have a to-do list, otherwise it wasn't a good use of my time. So for those of you who think like me, here's a to-do list that you might want to think about, and we'll go through it quickly so you don't fall asleep. When you think about using data to be a data-informed, outcomes-driven agency, what can you actually do? And I think that first and foremost, at your agency and across your community, you really have to have some sort of logic model. Raise your hand if you've ever had to fill out a logic model for a grant. Raise your hand if you ever actually did it last in the planning process. Have you? We've done that before. That's not good. There's some really great resources, and if you Google the Kellogg Foundation, that is my favorite resource for getting a free book on how to develop a logic model. The CDC also has one that's good, but Kellogg Foundation's a good one, and it's basically saying what you have to invest when you put it in there. You should have some good stuff that comes out that you can measure, and then you can have some really good stuff that's sustained over time. And the logic model is what reminds you, it's kind of like your compass to make you keep going north as an agency or an organization. Secondly, when you put together a program, let's say you're going to build a new program that's a mental health service for kids under 3. When you think about what you're going to measure, look to the literature, do a basic Google search. It doesn't have to be rocket science. Look for nationally recognized outcome indicators, and that's that idea of how are we making sure we're speaking a common language? How are we making sure we're all paddling the same direction? So look for nationally recognized indicators, measurement tools, reporting systems, etc. Emphasize outcomes over process, and that has been really critical for staff retention in my own program. When we sit down, we talk about how our families are improving. That is really inspirational for a staff in a staff meeting versus just pure performance kind of data. Within your program, thinking about improvement and accountability across all programs. And one thing I would say about that is so important, that idea of accountability. So I co-direct a mental health program that's statewide in North Carolina. And we got the holy grail of funding from our General Assembly, which happened to be a Republican General Assembly. The reason why we were funded was not because we went in there and said we're going to help a lot of children. What we said is we're running this really accountable program where bad clinicians get kicked out, and we will come back to you every year and show you how kids are better and how they are more likely to be productive members of society and taxpayers. That accountability actually got us funded. I think Claudia mentioned, it's not good enough to report back to your, internally or to your external sources about national outcomes. You actually have to report on what you're doing at your individual sites. And then this one cannot be overemphasized enough. Data collection, if it feels like an after process, something you have to do to write stuff down, to turn something in, it's not going to be useful. You actually need to be collecting data as part of your normal work routine, and it has to feed back and actually inform the people who work in your agency, but also inspire them. I put this here because I went to medical school because I'm not good at math. There was pretty much not a lot of other stuff I could do because I'm just bad at math. Excel is something that even I can use. It's really simple. I promise you, all of you have it on your computers. And this is really the foundation for data collection. You don't have to have $1 million system. You don't have to have that old tired conversation about legacy systems. You just have to open Excel on your desktop and start counting. I'm not going to spend a lot of time on barriers because in 20 minutes, who wants to talk about barriers? But I would just say in the data collection world, it's hard. It's not easy. It has to be a commitment really driven by a leadership who sees its value in a CQI world and in an outcomes-driven world. If I have like 3 more minutes, I'm just going to put up a few slides. It's really not to talk about my program so much. It's about talking about how like a bunch of pediatricians and psychiatrists who don't know anything about math were able to start this idea of being accountable by being data-driven and outcomes-driven, and again, using Excel on our desktop in our original iteration. So the bottom line is this. This is, looks confusing, but it's not. On the far left, you have stuff that you've done that you can measure. It's usually measured in numbers, and you put it somehow into the system. That can be staff talking about a kid being better or not. That can be an external fidelity coach saying that staff member did a good job. Or it could be independent outside monitors, like in North Carolina, we have managed care organizations that look at our mental health. So that's the stuff going in. In the middle, we have our data collection system for mental health services. We call it our Performance and Outcome Platform, or POP. And the idea is, if you are regularly doing this kind of data input as part of your normal work functioning, you accidentally get this really neat, rich source of information telling you how a large population of kids or families are doing. So we certainly have case-level outcomes, but you can add it and get averages in really simple math to understand how that population is doing functionally from a symptoms perspective. We can also look at performance. How is that clinician doing? If they're doing an evidence-based treatment model, it's measurable. Do they do good or bad? And if they did bad, you kick them out and move on. Utilization. How well are kids engaging in services, and are they liking it? And then there's this idea of data access. Well, it would be silly for me to know all this great stuff about kids and just have it on my desktop. So you have to have relationships with state agencies and things like Blue Cross Blue Shield and third-party payers to say, you know what, this is an investment in my program, but at the end of it, you have kids that are more functional and doing well. I'm not going to spend a lot of time getting into all this, but the slides are available for you all. The idea, though, is we really have a rich source of really important information about how a child is doing, so that's case-level information. This is, again, Excel. It's not magical. It's not a big, expensive computer system. I can look at one kid and actually see they're really healthy and doing well. I can see pre-treatment in blue. Gosh, they had lots of symptoms. And post-treatment in red, they're way better. And so that kind of information is really powerful to share with families, with staff, that kind of thing. So that's case-level data. Again, you can aggregate all that stuff and really look at how your program is performing, how your population is doing, how your system of care is impacted. This is just, again, Excel. It's really wonderful. This is a whole bunch of kids who got treatment, and what we were able to show to our legislators is that if a kid gets really good treatment with an evidence-based model, they're actually going to get way better than kids who didn't, and that's really powerful. It's worth investing in then. I did want to point out one thing. It's the same exact graphic as before, but you'll see on the data input side of things, there's in red, it says System of Care Administrative Databases. And the idea is if we know tons and tons about a family getting a service from us, wouldn't it be neat to follow that family over time to see, did they show up in a WIC office? Did they show up getting unemployment? Did they show up in the Department of Corrections? Did they show up graduating? Basically being able to look at across the system and say, how is that kiddo doing after they got this intervention from us now and over time? And it's very cool. I'm not going to spend a lot of time on this. It's, the idea is, this is in the slides, there's really powerful information. We can, for example, we have maps of our workforce. We can actually go to our managed care organizations and say, we have one provider who can do parent-child interaction therapy for 5,000 kids in the population or whatever. That's really powerful for them to say, gosh, our workforce is not sufficient. We need to invest in more training and more development. So that kind of information has been wildly helpful. And again, just really that idea of you really understanding how the interventions you're selecting works. You know, when you're in a program, you do stuff that you've always done, and it's really hard to prune things and cut things out. But in a world of limited resources, if you have a fixed amount of money and lots of different programs, it might make more sense to really look at how those programs are performing, what kind of outcomes they're getting, and prune things that aren't as successful. And so that's a way of thinking about things kind of with more of a business mind around health and human services delivery. 2 minutes, good, perfect timing. I'm going to have one last slide, so my timing is good. The idea is data really should be your driver. When you go to work every day, you're there to make people's lives better, obviously subjectively. You know, they feel better. But also objectively, there's a point to investing all these dollars and all this time. And so what I would say is data can be your driver in your community-based program at the individual level, but also as you plug in with the other system of care kind of agencies in your community. And what I would say is when you start to collect data and make that part of your routine practice, it really can be a driver for all these sort of important things like policy and programming, budgeting, legislation, et cetera. And so I think data can essentially be your friend. And a really interesting economist, Milton Friedman, has said one of the greatest mistakes is to judge policies and programs by their intentions rather than the results, and I tend to agree with that. So I'm going to turn That's not my slide. I got all the credit, and it was Neal's. This is Neal's slide. He's next.
Thank you, Dana. So, Neal, can we come back to your family with the 4-year-old?
Sure.
How could that have been different?
Well, I mean, I think that there's a number of things. From my perspective, there are things like family navigators. There are folks who've been through this before who, if that mom was connected to somebody, you know, as I listened to Claudia and Dana talk, I kept coming back to this idea that we spend so much time trying to help children figure out connections, how to connect with their peers and things. If we help families build those connections, family navigators, maybe having a mental health consultant in the program so that there's much less sort of risk that this child needs to leave the program, but a mental health consultant could actually do something. I think the other piece is about facilitated referrals. I worked with a mom once who said that over the course of 12 years, she got probably about 50 referrals. And I, like Dana, don't like to do math in public, but I think that averages out to like every 3 months she had a referral for 12 years, and her child still ended up in jail. Giving someone a piece of paper and trying to get them to go somewhere else is not an answer. Giving someone a referral and knowing where you're sending them and knowing that it actually provides the sort of support or service that someone needs could really help a mom like this. And then lastly, I think living in a community where everyone thinks that mental health is their business. Mental health is everybody's business. I always tell people this, that Jerry, who works at my grocery store, actually does mental health. She has no idea. I don't even know Jerry's last name. I've been going to her for 15 years. My children are 15 and 16. But she knows my children. She saw them. I have twin boys who are 16 months younger than my daughter. So she remembers me sort of pushing through her line with these 3 tiny kids, and she'd say how cute they are. And then she'd see them in their soccer uniforms and hear how much they hated soccer. And the fact that she actually asked them, how's your day, or how did your team do, that's mental health. I know we like to make believe, we psychologists make believe that it's actually this secret thing that we make believe an hour is 50 minutes, and we charge you an exorbitant fee for us to sit and talk to you. But if people start to think about mental health as everybody's business, this mom would have a lot more support. And I think those are just a few things.
That's such a great point. Claudia, did you want to add anything?
Ditto. No. I think it's really important too. A lot of times we ask people to screen or to talk to parents and make, but if they don't know where to make those referrals, it's really difficult. They need to know who the person is on the other end of that service that they're referring to. So I think that's really important. Just one quick example in Colorado, sometimes in my job what I do is go out and monitor mental health centers, and I was so struck by this one file that I read where it was a 16-year-old girl who was threatening suicide. But when I read back in her file, at birth, that community knew she was in trouble because she was a failure to thrive baby. And just how many opportunities along those 16 years where we could have provided some services. So, I mean, I think it's really true. It is everybody's business.
Thank you. Dana, I want to come to you and ask you a question.
Sure.
Given the essential nature of data to this work, how do you get everyone in the community to share their data and make sense of it at the community level?
Yeah, so in North Carolina, the experience that I've really had with data kind of being a collective enterprise is groups like child welfare calling together kind of roundtable and consensus kind of discussions. And in general, you actually have to have somebody fairly clever in the room who has access to the data and good ideas about how to use it. One thing that I saw that was just incredibly interesting is there's a fellow at UNC named Dean Duncan, and he does a lot of research on child welfare populations, but his methodology is interesting, and I think it's something you all could think about taking home. He basically looks at a lot of kids that are getting served by a particular system, and his area of interest happens to be child welfare. But what he did is he assigned each kid like their own unique number so that you could follow them through the system. And what he did is he followed this huge group of kids in child welfare, they happened to be in foster care, and followed them after they left foster care and saw what happened 5 years after they left. And the interesting thing that he did was he actually got permission to look at the Department of Corrections, to look at unemployment claims, to look at who had a parole officer, to look at who graduated high school. And there was just some really interesting things that he learned about those kids. I won't go into tremendously interesting what made them special, but the idea of you going back to your home states or your communities and saying, you know, I'm running this program, I'm giving this very intense service, does it matter? And can I pull together other people doing really intense services? And let's look at our data together and say, collectively, what did we actually do for this family? And let's be super clever and get somebody who has access to administrative databases. Let's see how this family is doing. Let's watch them over time. I think it's not easy. It involves a lot of getting permissions. But what we've learned in North Carolina is if you have the right people at the table, it's actually doable. So I would strongly suggest going back and thinking about other parts of the system of care, bringing them together and asking, how can we look at this administrative data, all these things we know about all these families sitting in separate places, and bringing them together for a clear snapshot.
That's great. Thank you. And Claudia, you talked about, you gave a great example of your mission statement and how parents gave you some fabulous feedback to make that more real. How do we, you know, if we all know that feedback loops are so important, how do we ensure that our practices are informing policy just as much as policy is informing the practices?
I think there's a couple ways. I think it's really important to have both informal channels and formal channels. And so informal channels are, I think it's really important for state people to get out of their office and go visit communities. And I think they need to do that on a regular basis. There's just so much information you obtain from being somewhere. And then conversely, I think it's really important that community people reach out to state people. They are really hungry for what's happening in communities. And so if you have a report or an innovative program, I think it's important to reach out on an informal basis, as well as I think it's really important that there are structures and there are intentional ways that feedback happens. And so in Colorado, one of the things is, I think you have to work at each level. The community level, our councils, they organized into an early childhood leadership alliance. So they sort of have like a trade association for the local councils. And then there were structures where the mid-level folks got together, and that was important because mid-level people are going to be there for the long term. When you get to the very high officials, they kind of come and go with the political winds. But then we also had we needed them too, so we also had structures where the high-level folks were. So I think it's just important that there's organization and structure at all levels, and that they communicate.
That's great. Does anyone want to add anything to that? So Neal, I'm going to come to you and ask if you have any final advice that you would give to those embarking on this community-wide systems work.
Yeah, so a couple things. It's interesting, Claudia, that you said sort of get out of your office, because as I've been listening, Charlie Biss, Children's Mental Health Director in the state of Vermont, got a federal grant to build a system. So he said to folks in other agencies, let's go out to the communities, let's hear from families, let's find out what's really going on. And so, like any good state employee, they were given some filthy, nasty van, and they all got in this van. All these people worked in different agencies, child welfare, educate, whatever it is, and they had to drive around together, and they built these connections that really helped them understand what was happening in communities, but also built their connection. Yeah. That they were all in this together. And I think as I listened to both Dana and Claudia emphasize data and outcomes and how you actually use that to sort of achieve an adaptive change. That's where Claudia started. This is not, there are technical solutions to everything you're doing. There's all kinds of evidence-based practices, and there's 55 manuals that will tell you what to do about building collaboration. But it's an adaptive change. It's an you talked about this, things evolved. And I think that the two things that came to mind the whole time were quotes that I heard from folks who built systems. One is, money makes you stupid. meaning we could throw money at stuff. It doesn't really actually make anybody do anything differently. It just makes you a little bit more hungry for more money. The other one was a guy who said, you know, when we were thinking about our system, we didn't want to build a rock so big we couldn't move it. And they're sort of connected. The idea that you have to have a vision of what you're doing and not just take all the money that you can get by writing grants and getting people to give you money and just building something that's not going to sustain. That you want to build something that is in for the long haul, and using the data and the outcomes, as Dana's pointed out, to help build that rock that's sort of an achievable sort of system is a really important thing to keep in mind.
You know, you're reminding me, in a session I was in this morning, I heard that from a system scan work that was done in one county, what they came to understand was that working on the system was more important than bringing in new programs.
Mm-hmm. That's good.
Claudia, do you want any advice?
I would just add, I think it's really important to look at the programs and systems that you already have and see how particularly mental health work can be infused. We decided, as Neal said, you can't build a separate system, so what is it that the existing systems could use, and what language do you need to do to connect with them?
Dana, anything to add?
I would just say, don't be afraid to prune. That means after you spend a lot of time building something and you've geared up your staff to be able to do something, it's really scary to say that's not what we were hoping for, or those aren't really quite the outcomes. So in our own program, we're building a mental health service array, and there are some evidence-based models that we're using that are for kids under 3. There was one particular model that I won't specifically mention, but we spent a lot of time and a lot of resources building it, and it just we weren't able to get the mental health outcomes we were hoping to get at kind of the population level. It was really an ivory tower kind of thing that just was not scalable, and that was a really hard lesson to learn. So what I would say is, be brave enough to stop doing that, something that you had started or invested a lot of energy or money in. Be brave enough to stop.
That's great advice. I'm going to turn over to the audience now, to any of you that have questions for the panel. We do ask that you use the microphone. We have one in the center aisle here so that everyone can hear your question. I'm sure someone is willing to start. No questions? Here we have one. Okay, thank you.
Good afternoon, everybody.
Good afternoon.
I'd like to get a little more information on how you were able to leverage the family navigators to work together with the mental health teams to get the outcomes that you were looking for.
Is that for me?
Whomever would like to address it.
Family navigators.
I'm sorry, so which stakeholders were you talking about? You were talking about the funders, which?
The family navigators. Neal, did you speak to
So
that?
I'll take a shot.
Yeah.
So thanks, Valerie. So here's a couple places where family navigators are. Here's a few places. In Maine, in a project launch site, so in a very you sort of go to the end of the United States and you make a right, and before you get to water or Canada, that's where it is in Maine, a very rural part of Maine. They thought the only way that people are going to really understand how to navigate this system is to work with somebody who's already been there. So they've had Project Launch, they've had a big federal grant. That's the challenge in most places, is you need some sort of startup money, because not as many places have figured out how do we actually pay for something like that. So I mentioned Alamance, North Carolina. They had a System of Care grant and a Project Launch grant. That's probably $12 million of federal funds. On the other hand, there are places like Arizona where they have worked with their Medicaid offices to say, this is an important service. It's not the only place, but it's an example. This is an important service, and people who are doing this service, we shouldn't just try and figure out how to fund them for a little bit and then the funding goes away. We need to make this a Medicaid billable service. So in some states, there are ways in which there's sort of peer support and sort of family navigation. What that takes, and Claudia could probably speak to this really well, and Dana as well, is you have to somehow sit with somebody from Medicaid, which is not always easy, and sometimes take some time to help them understand why you would want to actually open things up and talk about what Medicaid pays for and it doesn't. There are numerous examples. In Alaska, Medicaid actually pays for things like tundra walking and blueberry picking as therapeutic services. Why? Because there's a number of Native Alaskans where that is actually a therapeutic intervention. I don't think they'd pay for tundra walking in North Carolina. If they did, that would be really cool. But I think that there are these examples where folks have figured out, either through a grant and then use data to sort of show how effective it is, or by really sitting down with Medicaid folks and saying, this is what we need, this is what works, these are the outcomes from it. So that's sort of some initial thoughts.
Another thing I would say is that when we had our System of Care grant, we were using wraparound, and at first there was a bit of resistance from the early childhood community about wraparound because they felt like there were a lot of other planning processes that were already happening. So what we did is we did a very intentional study. We took all of those different planning processes and we matched them up to the values and principles of wraparound. And what we found is actually in early intervention, the family support plan was pretty close, actually, to wraparound. And by adding just a couple more components, we were able to develop one plan that all the professionals could use. So that was a really helpful way of looking at it. The other thing I would say about Medicaid is it took us some time, but we were able to convince our Medicaid office that family advocacy or family navigators was a type of peer support, because traditionally peer support's been thought of as for adult consumers. And I will let you know that CMS did come out with a bulletin that actually says, yes, family advocacy can be considered peer support.
Another courageous soul. Thank you.
So thank you. This was a really interesting session all put together. I guess my question, I love me a logic model more than anyone. I'm curious, because I work on a collective impact project, how we represent the system in a logic model in a way that is both understandable but also informs our evaluation planning. Because it's a struggle, I think, to include all of the activities, outputs, outcomes, both from the backbone side of things and then also from the program or activity side of things.
That's a great question. I think the way I have experience with one project in North Carolina that was federally funded. It was for child welfare in particular, and the idea was how do we make child welfare more trauma-informed. And so in that particular instance, the way it worked was our child welfare agency, our state child welfare agency, the Division of Social Services, actually was the leader. They were led the charge. And they pulled together a really interesting group of people that represented different parts of the system of care, as well as experts in evaluation and sort of setting up data collection. And from the very beginning, it was a collective effort to make a logic model where all the parts of the system of care plugged in and kind of said their bit. And in the end, what we all do is kind of the same. And so really, it was pretty, it wasn't that hard or complicated, and there was definitely no tension about any parts of the system being more important. So I think it was just the idea of a state agency being the leader, having some degree of authority, and pulling together the right people and say, let's plug in this idea of what we have that we're going to invest and where we want to go. And then the middle bit, let's kind of jockey to figure out how we're going to get there. And it's a great process.
So I would just add that the early childhood, so we're doing the collective impact model also with early childhood, and that framework that I put up there, that's what we use to capture our information. So we could look at that framework. Those were the outcomes that we all agreed on, and we could see which programs had interventions that were addressing those outcomes, and so we measured our progress that way.
Thank you. Really great question. Thank you. Any other questions? We have a few more minutes.
Hello. You mentioned, you mentioned foster care, and I'm interested in how you found services being rendered to those families, and whether or not they're truly connected to the community, or if it tends to be basically isolated to the social service system.
That's for me?
Yes.
Yeah, so I had made a reference to Dean Duncan's really neat work looking at child welfare populations, and so I would encourage you to Google him and look at his population stuff. But in our particular program, we were originally grant funded before the General Assembly stepped up, and the really interesting thing that we found is in North Carolina there's 100 departments of social services, and what we did is we really partnered with them very carefully and said, who do you like to refer to in your community for mental health services? And once you give us that list, we're going to go to those people and say, can we train you how to do good mental health services? So from the get-go, we partnered with DSS because our original frame was that we were going to deal with trauma, and that's where we figured a lot of that high-end stuff would concentrate. The neat part about that was when our grant funding dried up, there was kind of what we call the scorched earth phase of our program when there was like no money. It was the State Division of Social Services that called us and said, your program can't go away. You partner so closely with our social workers. We are going to provide X number of hundreds of thousands of dollars to keep you going until you can find better funding. So it wasn't even mental health that stepped up to the plate, it was child welfare. And we have just had really good working relationship with them since day one. And I think that's largely because professionally we started the program to serve kids like that. So what I would say is in relationship and then following those kids closely.
You know, I just add a couple of things. You know, I think that when we think about child welfare, when we think about foster care, foster parents, biological parents, that part of what some places have done is said, this is really about all of us working together. It's the same child. So if a particular child's in the foster care system and they have mental health needs, oftentimes what happens is there's some mental health person working with that child in the foster family and not paying any attention that the child welfare system's involved, and there's some other care coordinator and those kinds of things. There are places in New Mexico, they've sort of taken this federal mandate around CAPTA. It'll come to me probably on the plane tonight, but you're all whispering. You have to actually say it in the microphone. It'll help. But
I think is it Child Abuse Prevention and Treatment Act?
So in their wisdom, the federal government oftentimes, and I'm funded by the Fed, so if there's someone here, I apologize, but they'll sort of make things up and then they won't put any money behind it. But the idea is that there's some trauma involved in entering into the system, and if we place mental health folks in child welfare, they'll actually pay attention to that. So in New Mexico, they've actually paid attention to it. They've taken their early intervention folks and said, let's pay attention. Let's sort of connect all of these systems. I'm going to say it's Greenwood, South Carolina. I can't be sure because it's been a while, but I think in that community, they placed mental health workers in the child welfare office so that they could connect for both foster parents and biological parents the issues that come up when children are removed from someone's home. And I think there are great examples. I think there's plenty of examples where it doesn't work so well, but there are lots of examples of where folks have really said, we have to work hand in hand because of what happens when a child sort of enters into this system.
That is what prompted my question. I was curious as to whether or not they stay within the DSS system, or if they're truly connected to services within the community, which would deliver the best impact.
I would tell you that there are examples in this country of places that have done a really nice job of making the connections. And I'm sure that there are people in this room who could tell you lots of places where those connections have yet to be made. But yeah, there are lots of good examples. Los Angeles, that was a big emphasis of when they received a system of care grant from the feds. That was sort of the emphasis is that we're working with all these children and families in foster care. They have to be connected because they go to school and they're receiving special education services in some cases. How are we paying attention to those sorts of folks who are doing that work, and the folks who are working on the child welfare side, and the folks who are working on the mental health side, and the folks who are working on reunifying them with biological parents, and all those kinds of things. There are examples of it.
There's a program, a pilot in North Carolina called Partnering for Excellence, and the idea is that kids were coming into the child welfare system, not even just foster care, but the system, And local mental health had no idea that they had come into care, and the managed care organizations had no idea they came into care. So it was this idea of a really high-risk population of kids existing and not getting any services or evaluation or anything until they had a blowout. And so what happens is now that when a child, certainly when they come into care, they get a comprehensive trauma evaluation as well as a broad mental health evaluation. And then in those particular counties, all kids, whether it's CPS or whatever, are screened for trauma. And so that idea of trying to make that link, it's really not easy work, surprisingly. You'd think those mental health and social services would be buds, and they're kind of operating in their own special silos, and there's not a lot of bridges. So that's hard work.
And I would just offer two things. Wraparound works really well, and that really helped us bridge community supports and child welfare. We have a number of stories where actually child welfare was able to back out of a case after all the community supports were brought to bear. And then also we're working on the trauma screening and assessment. I agree with Dana. It just seems like it should be a no-brainer, but to work between those two systems is really difficult. But we've created in the child welfare system an actual trauma screen that the workers use and complete, and then they send it over to a mental health provider for an assessment.
Thank you.
Thank you for the question.